type 4 hiatal hernia, Christina, but here on the right part is seen in gastric volvulus, which is a complication of a type 4, right? So it's both sides triad. What the triad is, what are the three clinical findings?
Is epigastric pain, retching without vomiting,
Yeah,
and you can't pass the NG tube.
excellent, fantastic, excellent, well done, good. Number 5, answers to number 5 in the chat, please. Answers to number 5 in the chat, please. All right, good. Number 6, answers to number 6 in the chat, please. Answers to number 6 in the chat, please. Okay, sorry about that, guys. Number 7, answers to number 7 in the chat, please. Number 7, answers to number 7. Good. Number 8, answers to number 8 in the chat, please. Answers to number 8 in the chat, please. Your answer number 8. I was watching the screen, sorry. I'm not sure if you all answered. Or does it start from Daniel? And Celine and Soline. Celine and Soline. Okay. Right. Number 9. Answers to number 9 in the chat, please. Answers to number 9 in the chat, please. Number 10. Answers to number 10 in the chat, please. Answers to number 10 in the chat, please. Okay, great. Right, so that was a nice introduction. You all got most of them correct. It is fantastic. So we'll be starting the teaching now, straight into it. Alright, so we'll do upper GI first. I would have sent the guys in the group. For most of upper GI, I'll be teaching on the Painting app. Okay. You all would have seen in the group that for the upper GI, I would have also sent gastric cancer as a file because I don't teach gastric cancer. I think you'll only get one question on gastric pathology, and it doesn't have to be cancer, but it can be. So let's please read up about gastric cancer. It's a 4-page document I would have gotten from the Andrew Tan notes. It's pretty comprehensive. I mean, to teach a whole like 45 minutes on gastric cancer because it's a big topic and you're going to have one question and it is just not as effective as you just reading everything, right? But I will teach everything else. That's achalasia, good, esophageal carcinoma, as well as peptic ulcer disease and hiatal hernias, right? You all see the screen? Give me 1 second, huh? All right, cool. Yeah, so we're gonna get straight into it. And I am feeling a bit better. And my voice can be projected, so I will be shouting in your ears again. So you can lower your mics, your headphones, all right? All right, good day, everyone. Welcome to Upper and Lower GI from a general surgery perspective. Now, the reason I'm doing it this Saturday is because we would have gone through GI from a medicine perspective on Monday and Thursday gone. And classes were very long, but remember, learn GI, you're all going to get questions on it. And I think it was one of the most comprehensive lectures I have in terms of everything that we did. Most of your questions, 90% of questions from an MBBS standpoint, will be able to answer from our class and from our guide and the extra information I would have given you. Okay, so now we're going to look at things from a surgery point of view. And remember, I would have told you all that the esophagus, esophageal pathology, is hardly tested from a medicine point, and much more so, it's tested from a surgery point, right? So we're going to start off with the one of the most important topics to know about the esophagus from surgery. That's achalasia cardia. All right. So achalasia cardia. Good. So what achalasia cardia is, it is failure of the lower esophagus to relax. All right. So think about it like this. This is your esophagus here, right? And it's connecting to your stomach here, right? Good. So this lower portion of the esophagus fails to relax. And there are actually three mechanisms involved in achalasia cardia. All right. The three mechanisms that are there would be a loss of peristalsis, impaired relaxation of the lower esophageal sphincter, and increased resting tone. So this esophagus is not contracting the way it should. This sphincter fails to relax, so it does not relax to allow the passage of food. And the third thing that happens is, apart from it feeling to relax, when it is at rest, the tone is increased. All right. So what that means is basically you have a functional dysmotility as a result of achalasia cardia. So when a patient swallows, okay, they have difficulty with peristalsis to carry the food down into the esophagus. The sphincter is failing to relax, and then the tone of the resting tone of the lower esophageal sphincter is increased. All right. So what that will lead to is this finding when you do a barium swallow. When you swallow the barium, it's going to lead to this. Or this is what you'll see. The esophagus will be dilated. So on a barium swallow, the esophagus will be dilated. So you have dilation of the esophagus with retained barium in the lumen. You have a dilated esophagus with retained barium. What will happen is lower down here, you will notice a narrow tapering of barium flow into the stomach. So that's what we call a bird beak. Narrow tapering, which is a bird beak. Right? So you have a proximally dilated esophagus, barium will be retained, and then there's this narrow tapering, and that will give you a bird beak appearance. So despite barium swallow being what you all would know as the classical findings, what you'll associate with achalasia cardia, I want you all to remember what the gold standard diagnostic tool is for achalasia cardia, and the most specific way to diagnose achalasia cardia would be with manometry. So manometry is the gold standard of diagnosis. All right, manometry is the best and most specific way to diagnose achalasia. And on manometry, what you will have or what you'll witness is increased resting pressure of the lower esophageal sphincter. So increased resting pressure, and you'll also notice failure to relax, so incomplete relaxation. Right? And the increased resting pressure is more than 45 millimeters of mercury. And in many cases of achalasia, it's upwards of 80 millimeters of mercury. So there's such high pressure at the lower esophageal sphincter that the food cannot go down. All right? So manometry is the gold standard diagnostic tool for achalasia cardia. So because of those findings we spoke about in achalasia cardia, and you're unable to swallow, what's going to happen is the patient is going to experience dysphagia, difficulty swallowing. And this dysphagia in achalasia cardia is more likely to be to liquids in the earlies and then to solids. Right? Or they may coexist at the same time. And remember when we spoke about GI from a medicine point of view, when we spoke about mechanical obstruction or mechanical causes of dysphagia, we said that's due to something blocking the lumen. So difficulty swallowing solids will be the presenting symptom in your question stem. Whereas in functional causes of dysphagia, we will have difficulty swallowing liquids and then solids, and that's how they like to bring it. So achalasia cardia would more present with dysphagia to liquids. Because they have failure of the food to actually get into the stomach, these patients would present with regurgitation. And remember, the difference between regurgitation and vomiting is that for regurgitation, that's when the food is not digested and it doesn't reach the stomach. So you have passive expulsion of undigested food that hasn't reached the stomach. That's the difference between regurgitation. Vomiting is where you have digested or partially digested food being not passively but actively and forcefully expelled, and that's why you have that belly cramping and so on when you vomit. That's different to regurgitation. So because regurgitation, it won't cause vomiting. All right, because they're not able to swallow and get their nutrients, they'll have weight loss, of course, and that retained food would cause bad breath as it rottens. All right, so you have this putrid, small, foul-smelling breath. Because of that food in the esophageal lumen, you may have a risk of aspiration, and with that aspiration comes, of course, a chronic cough. Okay, so these are the symptoms that you will see in achalasia, and it all has to do with that mechanism of failure of the esophagus, loss of peristalsis, increased resting tone of the lower esophageal sphincter, and failure of that sphincter to relax to allow food to enter into the esophagus. So what actually causes this? Well, the mechanism behind achalasia cardia is where you have loss of inhibition. Okay, you have loss of inhibition, and this loss of inhibition is due to loss of the myenteric plexus of Auerbach. Myenteric plexus of Auerbach. So what that means is normally you will have an inhibitory response at your sphincter because your sphincter at rest is there. Of course, you want to prevent reflux. Okay, so in a normal person, the sphincter at rest will be contracted. And for you to swallow, you will have to inhibit that sphincter from being contracted. So when you inhibit the sphincter from being contracted, it relaxes and it allows food to enter into the stomach. But in the case of achalasia, you do not inhibit. You lose that inhibitory effect, and the sphincter remains in this elevated resting pressure and elevated contracted state, and therefore the patient is unable to swallow, and you have difficulty swallowing. And this is because of this loss of the myenteric plexus of Auerbach. And what is associated with this? Something called Chagas disease. Okay, so Chagas disease causes an achalasia-like condition, and Chagas disease is caused by the pathogen Trypanosoma cruzi, and we spoke about this because they really do ask this. Trypanosoma cruzi is spread by the reduvid bug, okay, which is also known as triatomony. All right, so achalasia cardia, failure of the lower esophagus to relax. You have loss of peristalsis, impaired relaxation of the lower esophageal sphincter with an increased resting tone. This is all because of you losing this inhibition because of damage to the myenteric plexus, and of course, Chagas disease is associated with it. The gold standard of diagnosis is manometry, and you would have increased resting tone with failure or incomplete relaxation of the lower esophageal sphincter. And achalasia is commonly associated with Chagas disease, Trypanosoma cruzi, the reduvid triatomony bug. All right. Now, because it's achalasia and because it causes dysphagia, you will do the investigations, you will do a barium swallow, and you will also, in all patients with dysphagia, you should do an endoscopy. All right. But that doesn't mean that any of these are the gold standard. They are not the gold standard. Manometry is the gold standard of diagnosis for achalasia cardia. It's the best way to confirm your diagnosis. All right. So that's that. As we're here, I remember last class someone had asked if trypanosoma is spread by the CC fly. So do you all? I hope that you all would have went and studied the CC fly, which trypanosoma is spread by this. We said it causes African sleeping sickness. And what's the pathogen's name that causes African sleeping sickness? Or you all didn't go and study it? This is important, guys, because when you get to tropical diseases and so on, African sleeping sickness, leishmaniasis, schistosomiasis, all of those things for infectious diseases, they ask you all about those things. Fantastic, Sydney, right? So it's T. brucei, right? Trypanosoma brucei. So this is the one that is spread by the tsetse fly. But the trypanosoma that we are speaking about, right, is not African trypanosomiasis. It is Chagas disease, which is caused by Trypanosoma cruzi. Okay, T Trypanosoma cruzi. All right, not brucei. This is the one that is associated with Achalasia cardia. That's particularly important. Good. So given that we know how to diagnose it, we know how it presents, we understand why you have those findings in the barium, swallow, and so on. How do we go about treating Achalasia cardia? Well, the treatment of Achalasia cardia involves medical management. It involves endoscopic management. It involves surgical management. Okay? So the medical management for Achalasia cardia, well, the sphincter feels to relax, so you want to give it things to relax. What will cause that? Smooth muscle relaxation caused by calcium channel blockers, smooth muscle relaxation caused by nitrates, smooth muscle relaxation caused by Viagra. Yeah, sildenafil, the phosphodiesterase inhibitors. So Achalasia cardia can be treated medically in this way, and these are the important drugs to remember from internal medicine perspective, of course, but also for general surgery. Endoscopically, it can be treated with pneumatic balloon dilation, right? Pneumatic balloon dilation. And of course, Botox, right? So your botulinum toxin. And then surgically, the surgical management of Achalasia cardia is a Heller's cardiomyotomy, okay? Achalasia cardia, Heller's cardiomyotomy. Not Ramsted's pyloromyotomy, not Nissen's fundoplication, because when they bring the questions, that's how they do it. They bring you the management for other pathology in the upper GI. Achalasia cardia surgical management is a Heller's cardiomyotomy. Now, yes, we have medical management, but the best non-surgical management of Achalasia cardia is the pneumatic balloon dilation. So this is the best non-surgical management. But of course, the actual best, most definitive way of treating it is surgery, right? This is the best way overall. And that's why this is a surgical topic primarily, because surgery is really the gold standard of management of Achalasia cardia. Now, there is one more thing that can be used to treat Achalasia cardia, and that is POEMS, right? POEMS is per-oral endoscopic myotomy. Okay, so it's used under endoscopy, and the difference between POEM and a Heller's cardiomyotomy is that this disrupts the mucosa, right? So remember, layers of your esophagus, we had mucosa, submucosa, muscularis propria, and serosa or adventitia. Well, your Heller's cardiomyotomy goes all the way down to the submucosa, but it does not disrupt the mucosa. Your POEM, your per-oral endoscopic myotomy, disrupts the mucosa. All right? So that's it. And that's Achalasia cardia. Okay, so there are medical management with CCBs, nitrates, sildenafil. Endoscopic management with pneumatic dilation, as well as Botox. Surgical management of achalasia is Heller's cardiomyotomy, and POEM is our last way of managing achalasia. Now, what's particularly important about a Heller's cardiomyotomy that I want you all to understand this concept, because you can ask this question. For a Heller's cardiomyotomy, the process is you're going to slice the muscles, right? So you just want to draw a little sharp knife here, right? This is supposed to be a knife, right? So it's going to slice the muscle. So when it slices the muscle, what that is going to do is that it will widen your esophagus and prevent it from actually contracting and allow food to enter. But the issue with this is what you have below your esophagus is your stomach. So the issue with a Heller's cardiomyotomy is that patients can have reflux as a result, because you are failing to prevent contraction of that muscle and lower esophageal sphincter. So yes, they can swallow, but it's an incompetent sphincter now. So now food can also go back up into the esophagus, and that is what we call GERD. And that GERD could corrode the esophagus and lead to Barrett's, etc. So a Heller's cardiomyotomy is often done with a fundoplication. Okay? And what that fundoplication is the same thing that you do for GERD, which is where you're going to wrap this fundus around here, right? And when you wrap this fundus around not too tightly, it would prevent reflux. So a Heller's cardiomyotomy is also commonly done with a fundoplication. Usually it's an anterior door fundoplication, which is not full circumferential. It's probably 180 degrees to 270 degrees, right? So it won't wrap all the way around, but wrap around just enough to allow food to enter into the stomach, but prevent food from backing up into the esophagus. Right? And that's a particularly important concept to understand with a Heller's cardiomyotomy, which is the treatment of choice for achalasia cardia. And that's it for achalasia. We done one topic. Any questions on achalasia cardia? I know that was fast. We did this in medicine. When can POEMS be used as it when Heller's fail? So POEM is not really the mainstay of treatment, right? POEM is this new form of treatment that some Asian guy would have discovered somewhere in Asia. Dr. Harry Ryan would have taught us exactly where and exactly who. But the mainstay of treatment is Heller's cardiomyotomy. Okay, so any other questions, guys? You're welcome. Any questions on achalasia cardia? Good. So I have everything in the guide. Good. Inhibitory, right? So you have loss of inhibitory neurons associated with C-Cruzy. Good, which is the kissing bug. We went through the clinical features, dysphagia, regurgitation, weight loss. We said the investigations are barium swallow, upper GI scope, manometry is the gold standard. For achalasia, this is your bird beak appearance. So look at it, you have your narrow tapering of the distal esophagus. You have dilation of the proximal esophagus with retained barium, and you also have this, delayed emptying, right? And this is all because of the loss of peristalsis, increased resting tone, and failure to relax the sphincter. Manometry, we said, increased resting pressure more than 45. So this value, guys, please note this value for achalasia cardia, elevated resting lower esophageal sphincter pressure. Oh, what I did not say is that achalasia cardia is a risk factor for cancer of the esophagus, particularly squamous cell carcinoma. Now, achalasia cardia can lead to adenocarcinoma as well, but it is by far more common to lead to a squamous cell cancer. And up to 10% of patients develop squamous cell cancer of the esophagus of about 15 to 25 years after the diagnosis of achalasia. So it is one of the etiological factors for SCC of the esophagus, but also adenocarcinoma. Good. We went to the medical management, CCBs, nitrates, and sildenafil. We went to endoscopic, surgical, and we went through POEMS. Good. Right? Are we clear on achalasia cardia, guys? Yeah? Fantastic. Right, I know I'm moving a little bit fast, guys. If you have any questions, let me know. Everything is in the guide, more or less, but when you see it in class, I think it helps you remember and understand better. Okay? So now we're going to do GERD. Are we going to do GERD from a surgical perspective? All right, we're doing GERD from a... So, I don't know what I do here. I do something, and now something is preventing my screen. Okay, right. Right. We're doing GERD from a surgical perspective. So we'd have gone through GERD, which is more a medicine topic. So we know how GERD presents. It will present with heartburn, it presents with nausea, vomiting, it presents with water rash. Oh, guys, does anyone know, because I saw this in a question I was doing recently, does anyone know the term for water rash or acid rash, the medical term for it? Because they asked which one of these symptoms is associated with GERD. Water rash, acid rash is basically the same thing. Acid rash is when the acid mixed with your food and you feel that weird taste in your mouth because the food is bubbling up in your esophagus and you get that sensation. So the medical word for water rash or acid rash, which one of these symptoms is associated with GERD, is pyrosis idiopathica. apparently. I never knew that. Okay. So I saw that in a MRCP question recently, actually. So pyrosis idiopathica. Okay, so that's one of your associated symptoms of GERD, and it is water brush. All right. So we know how gastroesophageal reflux disease will present. It's self-explanatory. What do I want you to remember for GERD from a surgical perspective is, of course, the gold standard diagnostic test. Yes, for GERD we can do things like endoscopy. Yes, because we know patients with long-standing GERD go on to develop. What do they go on to develop? Long-standing GERD. Barrett's esophagus. Fantastic, which is a premalignant lesion for esophageal adenocarcinoma, which we'll talk about. Right? So we do want to do endoscopy in some of these patients, but that is not the way of diagnosing GERD. The way of diagnosing GERD, the gold standard, is the 24-hour pH study. And what is the name of the score we use for the 24-hour pH study? Fantastic, the MISTA. Right? So there's this scale called the MISTA score. And this is what we'll use to diagnose it. So the gold standard diagnostic test for gastroesophageal reflux disease is a 24-hour pH study. That's particularly high yield. Now, the complications of GERD are more surgically taught, and that is GERD could lead to esophagitis, of course. GERD could lead to strictures. And very importantly for GERD is Barrett's esophagus. Barrett's esophagus, which can then progress to adenocarcinoma of the esophagus. Right? So this is what is particularly important to know about GERD from a surgical standpoint. The fact that 24-hour pH study is how we treat it, is how we diagnose it, sorry, and the complications, mainly Barrett's. And we would have said in our class on Monday that Barrett's esophagus, we need to know the exact definition of Barrett's esophagus. And remember, I would have drawn the picture, so for those of us who weren't here, the picture of what happens in GERD. How you remember the findings of Barrett's esophagus is that in GERD, you have your stomach here, and then what's going to happen? This acid is going to reflux, right? It's going to reflux. But where is it affecting? So Barrett's esophagus affects the lower 1/3 of the esophagus, right? So too does adenocarcinoma. And when this acid reflux into the lower esophagus, you have the cells going from flat cells, then it will become like a tumor. It will start to grow, and it now becomes columnar cells. All right. So what you have, how do you define Barrett's esophagus in patients with long-standing GERD? You have metaplasia of the squamous epithelium to columnar epithelium. So the squamous transforms, I should say, into columnar epithelium, so it starts to grow in the lower 1/3 of the esophagus. And this is your definition of Barrett's. It is squamous metaplasia. That is metaplasia of squamous to columnar, not columnar to squamous. What they always do is bring you columnar to squamous and try to teeth up your head and things like that. It is Barrett's esophagus. It is in long-standing GERD. That acid is going to cause metaplasia of squamous epithelium to columnar epithelium. And because it's due to reflux, it will affect the distal part of the esophagus, so the lower 1/3 of the esophagus. And that is particularly high yield to know the definition of Barrett's esophagus. Now, in patients who go on to develop this Barrett's esophagus, some of them we actually have to treat because Barrett's esophagus is a pre-malignant lesion. It ultimately will lead to cancer. All right. So what we have to do for them is we have to surveillance. Right? In patients who have high-grade metaplasia, we can do ablation. So we can do endoscopic ablation in these patients. And in some patients with Barrett's esophagus, to prevent that cancer, when we notice that it is extremely high-grade dysplasia, yes, esophagectomy is an option in Barrett's esophagus. It is not the go-to, of course, but just know you can cut out the esophagus for Barrett's esophagus. All right? So we have to always do surveillance on these patients who develop Barrett's esophagus due to long-standing GERD. And it leads to adenocarcinoma. Okay? Not squamous, adenocarcinoma. So Barrett's esophagus leads to adenocarcinoma only. Achalasia cardia can lead to squamous or adeno, right? But achalasia more leans towards squamous. Barrett's esophagus only leads to adenocarcinoma. That's a particularly high point to understand when we speak about risk factors of esophageal carcinoma, which is where most of the questions on esophageal cancer comes from. Okay? Again, from a surgical standpoint for GERD, what else you need to know about GERD would be the surgical treatment. And the surgical treatment for GERD is a laparoscopic Nissen fundoplication. And it's exactly what I showed you all before, where you're going to take the fundus of the stomach and wrap it around the lower part of the esophagus. So it's like this. This here fundus will come wrap around, and therefore it prevents reflux. Contents cannot go back up into the esophagus. All right, so that the name of that is a laparoscopic. It's done laparoscopically, Nissen's fundoplication, and this is the surgical modality of choice for GERD. Now, when we were speaking about GERD, we spoke about all the other management, so that's from a medicine perspective. But just remember, I told you all, do not forget the lifestyle modification factors. We said these patients need to have weight loss. They have to eat smaller portions of food more often. They need to elevate the head of bed at night. They need to avoid triggers like spicy foods and coffee and whatever. And very importantly, that I told you that I got wrong, is that these patients need to wear loose clothing. That is also an advised, evidence-based lifestyle modification for GERD, wearing loose clothing. That came in a question already. All right? Good. Not for MBBS. A question I saw in USMD. Right? So that's that. And of course, we have our medications for GERD. We have our antacids, our PPIs, our H2 antagonists, things that you all are familiar with. All right, but I just really wanted you all to know 24-hour pH study with the Demister score. Associate that with GERD. You know how it presents already. I remember Barrett's esophagus is metaplasia of the squamous epithelium to the columnar epithelium. So squamous becomes columnar in the lower 1/3 of the esophagus. All right, and this is a pre-malignant lesion, so we have to do surveillance. We'll have to do ablation in some cases and even cut out the esophagus in some cases. That's a judgment call. You're not going to be asked about that. That's fine. All right, and the gold standard surgical treatment for GERD is a Nissen's fundoplication. That's good. Any questions on GERD, guys, from a surgical standpoint? It's very easy. GERD is one of the easiest topics. Let's go to our guide. So GERD, clinical features, heartburn, acid brush, water brush, good. Diagnosis, history and exam, of course, endoscopy for surveillance to make sure they didn't develop Barrett's. And a 24-hour pH study is the gold standard with your Demister score. All right, we can't do barium swallow and manometry to rule out other pathology, but that is, of course, in keeping that you're unsure of a diagnosis, then we'll do everything. These are the complications of GERD. And remember, Barrett's esophagus leads to esophageal adenocarcinoma. Adenocarcinoma. It does not lead to a squamous cell, right? Because the mechanism is they have metaplasia of the squamous epithelium becoming columnar, all right? And in some cases, we do ablation and esophagectomy. These are all the lifestyle modification options. These are the medications. And of course, oh, right, metoclopramide. So we can have prokinetics as a to move stuff along. Prokinetics, for kinetic movement. So it would allow for the peristalsis to go from your stomach into your bowel. All right, so it prevents reflux. So metoclopramide can also be used in patients with GERD as a form of medical management. All right, so that's fantastic there. And laparoscopic Nissen fundoplication is the surgery of choice. Any questions on GERD, guys? Any questions on gastroesophageal reflux disease or achalasia cardia? Are we clear? Right, fantastic. Okay, so I will use Guy to teach hiatal hernia because I found this nice picture, right? Now for a hiatal hernia, it's a hernia. The hernia goes from the lower GI into the chest, basically, right? So you have your stomach or part of your stomach or part of your esophagus going from the abdomen into the chest cavity, intrathoracic. Now there are 4 types of hiatal hernia. What you all need to know about hiatal hernia are the actual types of it, the diagnosis, and the management is basically exactly how we manage GERD. In that we have lifestyle modification, it's the same medication, and in some cases, in some instances, we may do surgery. So a type 1 hiatal hernia is known as a sliding hiatal hernia. So that's this one here. Okay, this one here. So this here, this little small piece here, where you see my arrow, this is your gastroesophageal junction. This here would be our diaphragm, right? So what happens, right? What happens in a type 1 hiatal hernia is the gastroesophageal junction in a sliding hiatal hernia. The gastroesophageal junction is what lies intrathoracically. So because of that, these patients tend to develop reflux because you don't have this food going nicely into the stomach because the gastroesophageal junction is actually in your chest. So they develop GERD. So type 1 sliding hiatal hernia is strongly associated with reflux disease. All right, so that's type 1, where the gastroesophageal junction lies in the chest. That's type 1. A type 2 hiatal hernia is known as a paraesophageal hernia. This hernia is where you have the gastrointestinal junction remaining in the abdomen, but the stomach, the fundus of the stomach, comes up alongside it. So it's paraesophageal. So type 1, the gastroesophageal junction is in the chest. Type 2, the gastroesophageal junction is intra-abdominal, but the fundus of the stomach is what herniates, and the fundus only. And so because this fundus herniates, it can compress. It can compress the lower esophagus and lead to dysphagia. So a type 2 hiatal hernia, paraesophageal, would lead to dysphagia. Type 1, the gastroesophageal junction lies in the chest cavity, and therefore it leads to reflux. Type 2, the gastroesophageal junction remains intra-abdominally, but the fundus of the stomach herniates and it compresses and leads to dysphagia. Okay, so that's type 1 and type 2. What is type 3? Type 1 and type 2 together. So type 3 is where the gastroesophageal junction is no longer intra-abdominal. Type 3 is where your gastroesophageal junction comes intrathoracic, just like a type 1, as well as your fundus coming intrathoracic, compressing it as well, just like a type 2. So type 3 hiatal hernia is the combination of type 1 and type 2, right? So once you understand what type 1 and 2 is, type 3 is just both of them in one. Fantastic. So what is this thing called a type 4 hiatal hernia? So a type 4 hiatal hernia is where everything comes up. It is where you have your gastroesophageal junction intrathoracic, you have your stomach intrathoracic, and then in a type 4 hiatal hernia, also have other intra-abdominal contents. So you could have bowel in the chest, you could have spleen in the chest, you could have pancreas in the chest. So once you have another intra-abdominal organ coming up along with the other contents, the stomach and so on, that's a type 4. And because of all of these contents in the chest, it can lead to malrotation of the stomach. That malrotation of the stomach leads to what we call gastric volvulus. All right? So that's a type 4 hiatal hernia. So a type 4 hiatal hernia is where you have other bowel contents along with the stomach and so on into the chest wall. All right? So that's the difference between type 1, type 2, type 3, and type 4. And a gastric volvulus leads to 3 features, right? A triad of symptoms. That is Bouchard's triad, right? This has to do with a type 4 hiatal hernia, but this has to do directly, this triad is seen in gastric volvulus, right? Bouchard's triad. And what it is acute epigastric pain. These patients, they would have retching, but remember that part of the stomach is in the chest cavity, so it is retching but without vomiting because they don't have anything to vomit up because the stomach is in the chest cavity. And you also have, apart from epigastric pain, retching without vomiting, because of how the stomach is in the chest, you cannot pass a tube, right? Failure of the NG tube to pass. Failure of nasogastric tube being passed. This is called Borchardt triad. This is seen in gastric volvulus, and these are the features of it, right? Particularly high yield to know. Good. Right? So the features of a hiatal hernia would be good. And of course, the features of type 4 would be dependent on if they have a valvulus or not. But type 1 and type 2, type 1 would present with reflux, type 2 would present with dysphagia, and type 4 would present with, if the stomach end up going under volvulus, it would present with Borchardt's triad. All right, so just know type 1, understand the mechanism, and that's why it leads to reflux. Type 2 is paraesophageal, fullness of the stomach compressing the lower esophagus, but the gastroesophageal junction remains intra-abdominal. So when you have that compression, it's going to lead to difficulty swallowing. So that will present with dysphagia. Type 3 is type 1 and 2, and type 4 is everything up in the chest wall, can lead to gastric volvulus. All right? Particularly highlight about a hiatal hernia is this. The gold standard diagnosis of a hiatal hernia is not a scope, it is to do a barium swallow. When you do a barium swallow, you are going to see that barium showing the lining of your hiatal hernia. So a barium swallow is the gold standard of diagnosis for a hiatal hernia. Good. And we said that we treat it just as good. All right? And that's hiatal hernia. Any questions on hiatal hernia? It's of achalasia cardia or that's the next one we do there? Good hiatal or would type 3 present with good? Yes, Samuel. Yeah, it can because it's a combination of type 1 and type 2. So yeah, it can. Of course it can. And remember that GERD itself is a cause of dysphagia, right? GERD is a cause of difficulty swallowing. Why? Because GERD can lead to strictures. So GERD itself is a cause of dysphagia. Remember that. GERD is a cause of dysphagia as well, if you have a stricture. Yeah? Any other questions? Are we clear, guys? Are we clear on everything that we've done so far? Great. Cooking with gas. We only have 2 more topics. Love it. So the next topic here would be esophageal carcinoma. This is a commonly tested topic. It's tested from not a surgical point of view, but more a fact-based point of view. Okay, so that's how I'll be teaching it, more knowledge-based, right? So that's esophageal cancer, esophageal carcinoma, right? So there are 2 types of esophageal carcinoma. There's squamous cell carcinoma, and then there's adenocarcinoma. There are 2 types of esophageal cancer, squamous cell and adeno. Of course, there's all types of cancer. These are by far the 2 most common types. All right, so there are all kinds of different pathological types of any cancer, but we're talking about what you all need to know, right? So for all intents and purposes, there are only 2 types of esophageal cancer. And it's most likely to only be 2 types because you have stratified squamous epithelium, and sometimes this can become columnar epithelium. So once you understand the pathological basis of an organ, of viscera, you would understand the type of cancer. Same thing for colorectal cancer. Most commonly, you would have adenocarcinoma, right? So for esophageal cancer, we have squamous cell and adenocarcinoma. What you all need to know is definitely the demographics. The most common type of esophageal cancer worldwide is squamous cell. Okay? However, the most common type in the Western world is adeno. Why? Well, in the Western world, that's our side of the hemisphere and America and so on, we have a lot of junk food. We have KFC. I had only junk food today. I had double. I had fried pie. I had fried chicken, honey mustard wings, and I really need to fix my diet, especially that I'm getting sick. I need to eat some blue food and stuff, provision. But because of all that, we tend to develop GERD more often, and therefore we tend to develop Barrett's more often, and then we tend to develop, excuse me, we tend to develop adenocarcinoma as a result. All right. So the more common worldwide is squamous cell, but the more common in the Western world is adenocarcinoma. Overall, squamous cell carcinoma would be more common because it's more common worldwide, right? The location of this, most of it, of the squamous cell is in the upper and middle esophagus, about 70%. And for the adenocarcinoma, the most common location is the lower 1/3 of the esophagus. All right? So these facts here are very important to know. Don't just brush it over and read it over and think, all right, it's just a little statistic. I don't need to remember it. Yes, they ask you these kinds of things. All right? So more common in worldwide squamous cell, more common Western world adeno. Squamous cell more commonly found in the upper and middle, adeno more commonly found in the lower esophagus. All right? So what else do we need to know about esophageal carcinoma? So you need to know about the risk factors or etiology. So the risk factors of esophageal carcinoma. So we have to understand that this is divided into modifiable and non-modifiable risk factors. Okay, so we'll talk about the non-modifiable first. So achalasia cardia is a big non-modifiable risk factor. Once a patient has this, they have it. There's not much we could do about it. It increases their risk. And we said it increases the risk of squamous cell carcinoma way, way more than it increases the risk for adeno. Although it can do both, right? It can lead to either squamous cell or adeno. By far, achalasia cardia can lead to a squamous cell carcinoma more commonly. Other non-modifiable risk factors would be a Barrett's esophagus, because from the time this patient has a Barrett's, there's no going back. And Barrett's esophagus only leads to adenocarcinoma. Okay? Barrett's only leads to adenocarcinoma. Other non-modifiable risk factors would be Plummer-Vinson syndrome. You all remember the chart for Plummer-Vinson syndrome? Type it in the chat. Chart for Plummer-Vinson syndrome. Esophageal webs, dysphagia, and iron deficiency anemia. Right? And therefore, Plummer-Vinson syndrome would cause a mechanical obstruction because of the webs, which are a partial circumferential esophageal tissue. All right? So that's Plummer-Vinson syndrome. Next one is irradiation. Right? So if you had radiation exposure and tylosis. So what tylosis is this condition, very rare. It's a autosomal dominant condition, and the patient tends to develop hyperkeratosis of the palms and feet. So hyperkeratosis, right? So your thick skin is very, very thick. Hyperkeratosis. So your palms and the feet, right? And this is associated with esophageal carcinoma, hyperkeratonism, and therefore esophageal cancer, right? But by far the big things to remember would be achalasia leading to squamous cell more commonly than adeno, but it can lead to both. But Barrett's only leads to adeno. All right. So then, what are the modifiable risk factors? The modifiable risk factors. A little more space because there are many. Right. So the modifiable risk factors are particularly important to know as well, and that would be things like smoked fish. Yes, they asked this. Smoked fish is a risk factor. Certain food additives are risk factors. I don't know which ones, but I just know food additives is a risk factor. Alcohol, of course, is a risk factor. Someone is coming in the meeting. Sorry, give me a second. Somebody in the meeting. Okay, Kalima. Right? Alcohol, of course, is a modifiable risk factor. You can't control how much you drink. Coffee or hot drinks. So not coffee, because that makes it sound like coffee itself is a risk factor. I should say caustic injury. That's how it's said. So when you drink hot things and you have caustic injury, right? So you burn away your esophagus, that's a risk factor. Okay. Betel nuts. Betel nuts is another risk factor, and there's others. Let me just go back to the guide here, because I forgot some. Right, good. Particularly high yield is fight nutrition deficiencies. Right, nutritional deficiencies. They do ask you which ones, and the ones that are most commonly associated is a vitamin E deficiency, a selenium deficiency, and when you don't eat your carrots, a beta carotene deficiency. Right? So there's that, and this thing called smoking of tobacco. And I say of tobacco because chewing tobacco as well is a risk factor for esophageal cancer. All right? Obesity is also a modifiable risk factor because what does it lead to? Good. And what does good lead to? Good leads to this. Okay? So obesity and good. These are modifiable in that you can control good. You can do things to mitigate your risk of good. So you can modify good, but from the time it becomes Barrett's, that will indefinitely become cancer at some point. All right. So the modifiable and the non-modifiable risk factors of esophageal cancer, particularly high yield to know. Smoked fish, food additives, alcohol, injury, betel nuts, and these nutritional deficiencies, vitamin E, selenium, beta carotene. Smoking and chewing tobacco can lead to either squamous or adenocarcinoma, it doesn't matter. And obesity and GERD leads to Barrett's. So this would more likely lead to adenocarcinoma. Whereas the non-modifiable, as you say, they do always ask about risk factors when they're speaking about esophageal cancer. All right? So that's that. The next thing you need to know about esophageal cancer is they could ask what's the most likely diagnosis. So it's a presentation that you need to know. All right? Esophageal cancer, though it can be asymptomatic. So it can be asymptomatic. But esophageal cancer has this very, very unique way of presenting in a question stem, and that, of course, would be a progressive dysphagia with weight loss. Progressive dysphagia plus weight loss. In your question stem, this is esophageal cancer until proven otherwise. What I mean progressive, it starts off as dysphagia to solids, and as that mass grows, and it occludes the lumen, it leads to dysphagia to liquids after. So solids, then liquids, right, as the mass continues to grow. And that patient will be experiencing very severe weight loss. Now, they may also have things like lymphadenopathy, and they may also have compressive symptoms, right? And the compressive symptoms would be, where does the esophagus lie? What lies next to the esophagus in the tracheoesophageal groove? The recurrent laryngeal nerve. And that would lead to, of course, hoarseness of voice, right? Good. So this is the questions I'm looking for. Elderly patient with some of the risk factors and so on, and then they develop difficulty swallowing solids, then liquids, they notice some weight loss, they have some lymphadenopathy, they might have some hoarseness of voice. Remember that they could also compress the sympathetic ganglion and lead to Horner syndrome, which is the triad of ptosis, anhidrosis, and meiosis. PAM is horny, PAM, P for ptosis, A for anhidrosis, M for meiosis, as in pupil constriction, right? So look out for those signs, and that's how you would say that your most likely diagnosis in that case is esophageal carcinoma. The last thing that you'll need to know about esophageal carcinoma surgery, because they hardly ever ask management of esophageal cancer, is very complex. Most times it's chop out the esophagus. Sometimes it's just mucosal resection. What's particularly important to know about esophageal cancer is the diagnosis and the staging. So esophageal carcinoma can do a barium swallow, and you'll probably see the mass or the obstruction. But the gold standard, of course, would be to see the cancer under endoscopy. So endoscopy, and you'll take a sample. So this is your gold standard diagnostic test for esophageal cancer. Endoscopy is used to diagnose esophageal cancer. That is an upper GI esophageal-gastroduodenoscope. Upper GI scope is used to diagnose. It is not used to stage. The staging investigations for esophageal cancer can include PET scan, MRI scan, contrast enhanced CT, of course, a staging laparoscopy, and endoscopic ultrasound even. And yes, esophageal cancer can be staged with a bronchoscopy. You can tell if you have spread to adjacent structures. Please note, the staging investigations are different to your diagnostic investigations for esophageal cancer. So endoscopy is not used to stage, it is used to take a biopsy to see the mass to diagnose. The stage, we want to see if the tumor has spread anywhere, and therefore the staging investigations include these: PET, MRI, contrast enhanced CT, staging laparoscopy, ultrasound, and yes, even bronchoscopy to look for adjacent spread near your lungs and your trachea and whatever. All right, so that's that. The treatment of esophageal carcinoma is vast, but it's basically three principles. That is, you could do mucosal ablation. This is endoscopically done. Endoscopic mucosal ablation. You can then chop out the damn thing. You could do esophagectomy. The surgery is just chopping out things, ectomies. And of course, many of these patients require palliative care. And in that case, what can we do for patients with esophageal cancer palliatively? We can stent so that can help them swallow because the mass will be occluding the esophagus. We can do a little stent. But if it's spread throughout the body, there isn't much we can do to treat. We can do ablation. So these stenting and the ablation would be to alleviate symptoms, symptom alleviation. And then we could also do a palliative radiotherapy. Right? Good. And that's your treatment of esophagus cancer. And that's everything you all will need to know about esophageal carcinoma. Any questions on esophageal carcinoma, guys? Are we clear? The most important things for esophageal carcinoma by far would be your risk factors and your demographics. All right? So don't take those things for granted. Please learn them. Any investigations and knowing how to stage and diagnose it. Any questions, guys? Are we clear on esophageal carcinoma? Any questions at all? Good. We clear, guys? Yes? No? Maybe? Okay, good. So now we'll just go to the guide and make sure that I didn't miss anything. Right. Esophageal cancer, most common site is the middle. Okay, well, overall, I guess the most common site is the middle. It's more common in males, and we have two types. We said squamous cell is more common worldwide. That is a fact. 70% found in upper and middle. But it can be found anywhere in the esophagus. If I didn't say that, I don't think I had that on the slides. Smoking, diet, achalasia, predisposing factors. Good, good, good. Adenocarcinoma, we said, is more common in the Western world. Occurs at the lower one-third of the esophagus and associated with GERD and Barrett's. We spoke about our modifiable risk factors, so smoking or tobacco chewing. Excuse me. That's all, guys. Yes, sorry about that, guys. Still have a little mucus on my chest there. Right? Smoking, tobacco chewing, alcohol consumption, food additives, nitrates, good. Smoked fish. We said vitamin E, selenium, and beta carotene deficiency, betel nuts, hot drinks, and obesity and GERD are all modifiable risk factors. Non-modifiable was achalasia, plummer-vinson, tylosis, good. Irradiation and Barrett's leads to adenocarcinoma indefinitely. It's a pre-malignant lesion. It's not really modifiable in that to treat it, we'll have to actually chop out the esophagus. We said it's mostly asymptomatic and mimic good, but it's a progressive dysphagia with weight loss. Despite eating and despite a normal appetite, the weight loss is there because of cancer causes weight loss. Compression and lymphadenopathy. We said the diagnostic investigations are scope and biopsy, right? That's the gold standard for diagnosis. But the staging investigations do not include endoscopy. It includes all of these here, right? This is your TNM staging. You don't really need to know this, but I put it here for you guys. I've never ever seen a question on the staging of esophageal cancer. They do ask questions on the staging of colorectal and breast cancer. I've never seen a question on this. I just put it here so you could have it there, right? So you will learn this after you learn everything else, okay? The treatment is mucosal resection, you could do esophagectomy. These are the eponymous names. Some of them you do laparoscopically, some of them you could do through the abdomen, through the chest, or through the neck. Really, that's beyond the scope of any student's lecture and way beyond my scope because I'm not a surgeon. And palliatively, we could do these things. All right, good. So you went through that. Nice. And now, final topic for upper GI would be peptic ulcer disease. This is a big bad boy. You all want to push on through because we could do this topic. It's going to take about 15 minutes, hopefully. Could do this topic, push on through, then take our break. Yeah? All right. Fantastic. But I want you all to pay strict attention here, right? To PV, because this is, you're going to get a question on peptic ulcer disease for surgery. All right? Good. So that's a little basic understanding of peptic ulcer disease. Remember this thing here, this little scale? You all should have known this from like med school, year 1, year 2 kind of stuff, where you have protective factors, right? To the stomach, so you have protective factors, and then you have injury factors. I think that'll lead to mucosal injury, to be specific, right? So you have protective factors and mucosal injury. And this balance prevents the ulceration, which is a break in the epithelial lining, right? That's what an ulcer is, a break in the epithelial lining of the organ. So this balance prevents ulceration. But when you have a loss of the protective factors or an increase in the injurious factors, therefore you're going to have a tip in the scale, and this imbalance leads to a break in the epithelium and ulceration. What I want to point out would be what diminishes your protective factors, that is H. pylori. H. pylori does not work by directly damaging the esophagus. It works in a roundabout way by preventing the release of your bicarbonate and therefore increasing the effect that the hydrogen H plus acidic ions have. So it actually decreases your protective factors, right? Doesn't directly injure, it decreases the protective factors. What actually injures would be the acid cases. So Zollinger-Ellison syndrome, stress, and so on, could lead to ulceration, cancers, and so on. Things like that. Of course, any toxins. When we say toxins, we mean certain medications and stuff that could actually injure, right? So H. pylori reduces your protective mechanism. These things actually injure, and NSAIDs do a combination of both, right? So it both injures the mucosa directly and also reduces the protective factors via COX inhibition and so on. So when you have this imbalance, loss of protection, and increased injury, obviously you're going to have ulcers. So I just wanted you all to understand what does what. H. pylori does not directly injure it, it actually decreases the protection of the gastric lining. And NSAIDs does a combination, and all the things that lead to all the acids is what will actually increase your risk of mucosal injury, right? So that's just a little bit about the pathophysiology. So when we're speaking about peptic ulcer disease, we have two types of ulcers which we would have spoken about. You have gastric ulcer and you have duodenal ulcer. Which of them is more common? That's a question for you guys. Which type of ulcer is more common? Sorry. Duodenal, right? By far as well, right? So by far, it's more common, right? So duodenal ulcers are by far more common. Either way, we said that in your question stem, if a patient has pain on eating, that's more likely to be a gastric ulcer. If they have pain relieved by eating, that's more likely to be a duodenal ulcer. In real life, this is never really the case. In a question stem, it is. So look out for that. Pain on eating is gastric, right? As you're releasing more acid in the stomach. Pain relieved by eating is duodenal, as that is going to lead to chyme formation and actually reduce the acid secretion. All right. So what do I want to tell you? Studying how to teach this. All right, okay. All right. So what we'll start off with is the actual etiological factors of peptic ulcer disease, right? So for peptic ulcer disease, you need to know the causes. So etiology of peptic ulcer disease. By far, H. pylori is the most common. By far, by miles. Okay, it's responsible for about 70% of cases. So H. pylori infection is most common. Yes, we can have medication, and those medications include NSAIDs. Remember, patients on steroids have to be on a PPI, and patients on bisphosphonates have to be on a PPI, proton pump inhibitor, to mitigate the risk of ulcer. Steroids, NSAIDs, and bisphosphonates. The most common medication, of course, is NSAIDs, but the most common overall is H. pylori. So those are the two most common causes of peptic ulcer disease. Other things that could cause it would be Zollinger-Ellison syndrome, right? This is where you have gastrinomas. So gastrin secreting tumors. What syndrome, endocrine syndrome, is Zollinger-Ellison syndrome associated with, guys? So gastrinoma is a neuroendocrine type of tumor. So what endocrine syndrome is Zollinger-Ellison syndrome associated with? All right, so it's associated with MEN type 1. Okay. Yes, MEN type 1 is parathyroid, pituitary, and pancreatic. But Zollinger-Ellison syndrome, if a patient has Zollinger-Ellison syndrome, 20 to 60% of these patients actually have MEN type 1. So that's particularly high. All right. So that's another cause of peptic ulcer disease. So we'll call that, we refer to that as hypersecretory states, right? Where you're secreting a lot of acid. Of course, stress, right? Like physiologic stress is a cause of peptic ulcer disease. Yes, preparing for exams. I had a friend, she actually developed an ulcer while preparing for exams, and she had to go on PPI and stuff. Viral infections, and viral infections means CMV as a big one. Okay? So that's the etiological factors of peptic ulcer disease. Now, what commonly pops up in your peptic ulcer, in your ulcer questions is this, and just remember the difference between a Curling's ulcer and a Cushing's ulcer. Right? So Curling's is seen in burns patients, Cushing's is seen in patients with head trauma and elevated intracranial pressure. Right? So this is Curling's, RLSH. So Curling's is burns, Cushing's is increased intracranial pressure. All right, so please associate that. I saw that come for June and December, and I was like, hey, they're giving all the questions away. All right, good. What else do I want to teach you about peptic ulcer disease that's particularly high yield? Guys, whose classification do we use to classify gastric ulcers? Excellent, right? So this is particularly high yield, right? So we need to know our gastric ulcers classification based on a modified Johnson classification, right? So the modified Johnson classification helps to determine whether or not an ulcer is due to acid secretion and the risk of that ulcer bleeding and perforating in terms of a gastric ulcer, right? But we said by far more commonly are duodenal ulcers. Modified Johnson has to do with gastric ulcers, right? So how we classify them, I'll show you all the hypersecretory ones first. This is your stomach, right? Right. Sorry, let me just draw this. So I want you all to be able to take a picture of it so you can just do this here. Right. So let's actually do this one first. Right, this here will be our duodenum. Okay, this is our duodenum. This is our stomach here. All right.
Sir,
Yeah.
sorry to interrupt. I was just something I wanted to clarify. When you just spoke about the curling ulcers and the Cushing ulcers, you were just telling us about other gastrointestinal ulcers, right? And and not that it's related to PUD.
I was talking about other causes of GI ulcers, right? Not
Oh,
peptic ulcer disease itself.
okay.
Right? Peptic ulcer disease is because of all of the things we spoke about. Yes, a patient would be considered, I guess, peptic ulcer disease secondary to burns, and it would be a Cushing's ulcer. But I'm just talking about the questions that they ask you in MBBS. They ask you, in whom is a Cushing's ulcer seen, in whom is a Curling's ulcer seen, etc. Yeah.
Okay.
All right. Sure. Nice. So this here is our roundabout stomach, but it's just to get the point. This here is our pylorus. Right? So the first two that we're going to talk about would be where you have an ulcer here. So an ulcer here and an ulcer here. So where in the gastric ulcers in the modified Johnson, this is called a type 2 ulcer, where you have an ulcer that is in the body of the stomach, excuse me, plus the duodenum. So that's a plus a duodenum ulcer. So that's a type 2. All right. The next one we have is where we have one right before the pylorus. This is sorry, phrase that differently. This here would be type 3. This is pre-pylorus. Okay. Type 2 and type 3 ulcers, according to your modified Johnson classification, these ulcers, put it in red actually, these ulcers are the ones that are due to acid hypersecretion. These are the ulcers that have a higher risk of bleeding and perforating. Okay? So type 2 is body of stomach and duodenal. Type 3 is a pre-pylorus. These two have the higher risk of bleeding and perforation, and they are due to acid hypersecretion. So that's type 2 and type 3. Know the location and know that they are associated with acid secretion. So that's that. What about type 1 and type 4? Right? So again, draw. How do we put this here? Oh gosh. Right. Right. So a type 1 and a type 4 are actually on the lesser curvature of the stomach. Alright. So a type 1 is lower down on the lesser curvature. This is type 1. And this is a type 4, which is higher on the lesser curvature. Higher up on the lesser curvature. So a type, and this could also be found on lesser curvature slash body. Alright. A type 1 and type 4 ulcer, gastric ulcer, these are not associated with acid, not associated with acid secretion, and their risk of bleeding is low. Okay, so a type 1 and type 4 are not secondary to hypersecretory states. A type 2 and type 3 are. All right, and then importantly for a modified Johnson would be a type 5, and this is due to medication use, and it can be found anywhere on the stomach. So if a gastric ulcer is due to medication use, it is a type 5 ulcer, regardless of where it is located, according to the modified Johnson classification. That is guys, please learn the modified Johnson classification of peptic ulcer disease. I would leave it as that. Any questions on that? I think I have it here. I just wanted you all to see it and can't see how you never heard it or we never taught it, because it's right here. All right. So type 1, gastric body lesser curvature. Type 4, high on the lesser curvature. So this one on the right, this is a type 4 and this is a type 1. These are not associated with high acid states. But a type 2, which is where you have 2. Remember, type 2 is 2. You have a body of the stomach as well as a duodenal ulcer. That's type 2 gastric ulcers. And a type 3, that's along the prepylorus region. These are associated with the high acid states. All right. So please learn the modified Johnson classification of gastric ulcers. Okay. Good. So that's that. And now we'll finish off peptic ulcers by talking about, we'll talk about the investigation, of course. So for peptic ulcer disease, when somebody says something?
Yeah, Doc, is me, William. I had a question, right? In the little image that you finished just now, with the types, right? Is it labeled wrong? The prepyloric, is it pointing to the wrong ulcer?
I don't know. Probably. I can't really draw, but I just wanted to try and make a thing that way. So use this picture.
Nice picture, but
yeah, so this here, so this picture is more, I guess, accurate. I don't know. I was just trying to group together that we have a gastric body ulcer as well as a duodenal ulcer, that's a type 2. And right before the pylorus, a prepylorus ulcer, that's a type 3. Most important thing to understand is the word association of prepyloric being type 3 and duodenal and body being type 2, and to understand that they associate with high acids. Whereas the types 1 and 4 are both along the lesser curvature. The type 4 is higher up, the type 1 is kind of lower down, and these are not associated with acidity.
All right, thanks.
Yeah. Right, and type 5 is medication associated, regardless of location. Good. Right. So when we're speaking about our investigations of peptic ulcer disease, we were speaking about how we work up peptic ulcer from an internal medicine perspective. H. pylori testing is particularly high yield, right? Now, the gold standard way of diagnosing peptic ulcer disease is an upper GI scope. This is the gold standard way because why? You're going to actually see the ulcer, right? That's diagnosing peptic ulcer disease. But H. pylori testing must also be done in patients with PUD because H. pylori is the most common. And guys, just type out in the chat what are the 4 H. pylori tests that we would have spoken about in GI. As you all type, I will write. Right, so we have a stool antigen. We have a urea breath test. Good. We have serology. Right. And right. So endoscopy biopsy. Endoscopic guided biopsy plus histology. And which one of these is the gold standard for diagnosing H. pylori? Good. Biopsy. And which one of these cannot be used to assess response to therapy? Serology. Excellent. And which one of these is the best non-invasive test? No, the stool antigen is not the best. The urea breath test is the best non-invasive. This is the best non-invasive. Do I have stool antigen as the best non-invasive on my thing? Do I have that on my guide? Oh, okay. Sorry, guys. If you all see things, I will have to adjust something at the end of class. But if you all see things like I might have a little error, let me know, right? But yeah, for sure, urea breath test is the thing. Yeah. So yes, the stool antigen I never said that is the best for assessing treatment response, but it can be used, right? The best either way for assessing treatment response is a urea breath test, just to get that clear. I put that this is the real indication for it. The stool antigen, the best it is indicated to assess response to therapy, but it's still inferior to the urea breath test. The urea breath test can be used to aid diagnosis as well as it can be used to determine if you cleared the infection. So it is by far the best test, all right? But it's not the gold standard to diagnose. The gold standard to diagnose is to see the organism. But because biopsy has its risk and so on, it's very invasive, it is less commonly done, right? So we just do the urea breath test because it's non-invasive and it still has like a 95% accuracy. Good, but thank you so much, guys, for responding and like getting everything correct. Oh, you all are fantastic, right? So that's our investigation. But remember, for diagnosis of peptic ulcer disease, it is simply excuse me, it is simply a scoop, just to see the ulcer on the scoop. All right. So that's that. Now we're gonna do the complications. So the complications of peptic ulcer disease you need to know. There are 6. Bleeding. 1. 2. Perforation. 3. It can be intractable, meaning it never heals. 4. Penetration. It can penetrate and erode into surrounding structures. 5. Cancer. Gastric cancer. Right, this is a risk factor for gastric cancer, and when you all read gastric cancer lecture that I sent you, or the pages, and there's a 6th one, and I cannot remember it, and I do not know why I can't remember it. Gastric outlet obstruction, yeah, right? Gastric outlet obstruction. Gastric outlet obstruction, GOO. So these are the 6 complications of peptic ulcer disease. It can bleed, can perforate, can be intractable, can penetrate in surrounding structures, can become cancer, and can lead to obstruction. Question is, which of these is the most common cause of death in peptic ulcer disease? That's a question for you. Perf bleeding, perf bleeding, perf bleeding. Good, you all thinking? So it will be one of the 2. Bleeding, all right? So bleeding is the most common cause of death in these patients. Upper GI bleed, massive hemorrhage because of a, well, y'all will tell me. Y'all will tell me how a peptic ulcer, or what happens for a peptic ulcer to bleed. All right. So when we're talking about treatment of peptic ulcer, we're speaking about treatment of each of those complications and peptic ulcer before it becomes complicated. So to treat peptic ulcer disease would be the same kind of thing we would do with GERD and reflux and high acid states. That's lifestyle modifications. The same exact things we're doing for GERD is the same things we're doing for peptic ulcer disease, avoiding triggers. We have the medication for the peptic ulcer disease. That's our PPI, antacids, H2 antagonists, and particularly, I want you all to know about this medication, which is sucralfate, right? Because sucralfate can come from a medicine perspective, and I forgot to teach you all about sucralfate. So sucralfate basically covers and protects the stomach. Sucralfate has particular indications if it is to be used. Sucralfate can only be used for duodenal ulcers, not due to NSAIDs. Sucralfate also has low value in H. pylori, in ulcers due to H. pylori. So if you want to put patients on sucralfate, it has to be, they have to have a duodenal ulcer. It cannot be due to NSAIDs, and it wouldn't be too beneficial in patients with H. pylori. All right? So it is not for gastric ulcers. And I'm saying this because I learned this in GI. And I was like, I didn't know it before. And I know it now. And if they ask anything on sucralfate, I guess that's a thing there, right? That's also used in peptic ulcer disease, apart from your other mainstream medication. Right? And of course, for peptic ulcer disease, we have to, if the patient has H. pylori eradication. And in the chat, what is your drugs for triple therapy? H. pylori eradication, triple therapy. Right? PPI, clarithromycin, and amoxicillin. So if the patient have a penicillin allergy, good. So you'll switch out the amoxicillin for metronidazole. Good. I thought you all wasn't reading because I don't think I said that in the medicine class, right? So it's usually clarithromycin, amoxicillin, and PPI, but they might have allergies, so we give them some flagyl, right, which is metronidazole. And what are your drugs for your quadruple therapy with bismuth? All right, so it's a PPI and bismuth, and metronidazole and tetracycline, right? There's 4 drugs: PPI and bismuth, tetracycline, and metronidazole. Good, fantastic. And so you put that patient on that regime, either triple therapy or quadruple therapy for 7 to 14 days, 1 to 2 weeks. All right, so that's generally how we would try to treat our peptic ulcer disease. But what I want to go on to here is how we would treat the complications. And I guess I'll go back to the guide for that because I can't remember all of it offhand. All right. Okay, good. Right. So we said the complications would be bleeding, right? Oh, I had the answer there. Damn. So, all right. So how does the peptic ulcer, how does a duodenal ulcer bleed? What has to happen for a duodenal ulcer to bleed? Which artery is involved? And how does the ulcer erode? In which direction? Right? So it's a posterior erosion into the gastroduodenal artery, right? So that's fantastic. So posterior erosion into the gastroduodenal artery. And what is the most common site of a perforation of a duodenal ulcer? Anterior what? Anterior, Where? Okay, thanks, Lynn, right? So it's the anterior first part of the duodenum, right? So a bleeding duodenal ulcer is due to the posterior erosion into the gastroduodenal artery. So it erodes posteriorly into the gastroduodenal artery, but the most common site of a perforation is the anterior first part of the duodenum. Those two facts you must know. And so remember that's right there, because you know they like to see it on the screen and take pics. That's good. So bleeding is, let me put this in red, posterior erosion, right, into the gastroduodenal artery. Whereas perforation, let me put it in brown because perforation could lead to peritonitis, is the anterior first part of the duodenum, right? So I think this has helped you all remember stuff because that's what you all have been telling. So you can probably take a picture of that. All right. So that's that. Good. So now we're going to go into how we treat in these actual complications. And we're going to go into the principles, not into how you're doing the things, right? Let's go into the principles to get your distinction in surgery. So if you have a bleeding peptic ulcer, it is exactly what we went through for gastrointestinal bleed. We want to do investigation, CBC, diff, etc. Group and cross, coags, LFTs. And remember, elevated bond to creatinine ratio is highly suggestive of a massive or an acute upper GI bleed. When the bond is elevated in comparison to the creatinine, it suggests an upper GI bleed. And we said that could be because of the digested blood in the GI tract as well as renal insufficiency because of hypovolemia and hypoperfusion to the kidney. And that's why your bond rises in a upper GI bleed. Good. How would we manage it? First things first is aggressive fluid resuscitation. We spoke about that in medicine. You're going to put 2 large bore IV cannula and resuscitate with fluids. That's your next best step, right? IV resuscitation with fluids. In the case of a peptic ulcer, you'd want to infuse Nexium IV 80 milligrams. Well, in 80 mils, it's a Nexium infusion. All right, so that's a start infusion of Nexium 80 milligrams IV in 80 mils. If it was due to a variceal bleed, remember the drugs we said for esophageal varices was octreotide and antidepressant, but we are talking about peptic ulcer disease. Nexium would be our drug of choice. Now, for a bleeding peptic ulcer, it might require surgery. It might require endoscopy. And so for bleeding peptic ulcers, you need to know your Forrest classification. Just like you need to know a modified Johnson, the Forrest classification is by far more important out of the two. You need to know 1A, 1B, 2A, 2B, 2C, and 3. 1A is where the patient is actively spurting blood. 1B is where they're actively oozing blood. So 1A and 1B, they are actively bleeding. This will ultimately, of course, require some sort of invasive therapy, and that would be with endoscopy. All right? Type 2A, non-bleeding, but is seen in the vessel. Type 2B, there is an adherent clot. Type 2C is a flat spot with an ulcer in the ulcer base. So you have the flat dark spot. And type 3 is where you have a clean-based ulcer. 2A and 2B have a rebleeding risk that's high as well, more than 20%. So the point about the Forrest classification, you need to know, correlate 1A with active spurting, 1B active oozing, 2A non-bleeding but a visible vessel, 2B has an adherent clot, 2C has a flat spot in the ulcer base, and 3 is a clean-based ulcer. You need to know what they are. The reason, apart from knowing what they are, the reason for why we use this is to know when to intervene endoscopically. And that would be types 1A to types 2B, that's where you have the highest bleeding risk. And so you'd want to intervene endoscopically. And the options we have for endoscopic options would be injections with epinephrine to cause vasoconstriction, fibrin glue, thrombin, etc., sclerosants. You could use heat. So you have thermal ablation, right? Thermal, and you can just do clipping and banding. So these are your options endoscopically. None is really superior to the other, but if I had to choose one, I would always go for the clipping or banding or the heat to arrest the bleeding. All right, the cauterize. You're basically going to cauterize the area of bleeding. All right, so types 1A to 2B require endoscopic intervention. And when do we actually do surgery? And these are indications here. So surgery would be, of course, the suture the vessel, right? Simple concept. So if the patient has hemodynamic instability in spite of resuscitation, theater. If endoscopy fails, theater. Recurrent hemorrhage even after they stabilize them, theater. Shock, theater. Continuous bleeding, requiring transfusions, theater. Right? So let's learn all these indications for when to take a patient for surgery in the case of a bleeding peptic ulcer. All right? So that's how we handle the bleeds. So now Forrest classification. First, we'll do endoscopy. And if endoscopy, unless, of course, the patient is in shock or the other things, the other indications. But if endoscopy fails, then we could do surgery and ligate. And these are endoscopic methods, injections, thermal and mechanical options of clipping and staples and what have. All right? So that's a bleeding peptic ulcer. You need to read up a little bit about the Glasgow-Blatchford score and the Ruckle scoring system. And so the Forrest classification, the Glasgow-Blatchford score, and the Ruckle score are all used for bleeding peptic ulcer. Glasgow-Blatchford, Ruckle, and Forrest classification. Okay, great. Next is a perforated peptic ulcer. So we said that a perforated peptic ulcer, how will that patient present? And I wanted to clarify because I know students mix it up. So a peptic ulcer bleeds by erosion into an artery. So let's just show how the complications would look, just so you understand what's going on with the peptic ulcer, right? So this is your ulcer here. So one thing the ulcer could do is that it could bleed, right? And when it bleeds, the blood will go up here and it will go down here, right? So you could probably erase this. Sorry, guys. Just so that you're clear on what happens. What are the actual complications, right? So you can have bleeding, and that blood will go up in the esophagus or down the GI tract, and you could have an upper GI bleed or a lower GI bleed with Malina stools or whatever. A massive upper GI hemorrhage could lead to lower GI hemorrhage, right? And this is seen due to erosion posterior erosion into gastroduodenal, right? Gastroduodenal artery. So that's a bleeding peptic ulcer. The other thing that could happen is this ulcer could perforate. So it perforates and bust open. So this is a perforated peptic ulcer. And this happens most commonly in we are talking about duodenal. This is I know I draw a stomach. We're speaking about duodenum here because it's more common, right? I'm just doing it for drawing purposes. Perforation of the peptic ulcer. This does not cause bleeding, guys. This causes board-like rigidity. On exam, can cause rebound tenderness, and it causes severe epigastric pain. Sudden severe epigastric pain. These are what you're looking for. Does not cause bleeding. Perforation. Hi.
With regards to upper GI bleed versus lower GI bleed, we wouldn't use the ligament, right?
Sorry?
Wouldn't it always be an upper GI bleed because it's above the ligament of trites?
Yeah.
So we're just talking about if it'll present differently, but we'll never really call it a lower GI bleed because, I mean, it's in the stomach, right?
No, what I'm saying is a cause of a lower GI hemorrhage is a massive upper GI hemorrhage.
Oh.
Right? So a lower GI bleed could be due to a massive upper GI bleed. The primary cause is the massive upper GI bleed, but it can lead to a bright red blood. If you have an ulcer that is bleeding profusely, you'll have hematochezia. Those patients usually die.
Okay. All right.
Yeah.
Okay. Thanks.
Sure. No problem. Right? So perforated peptic ulcer, bleeding peptic ulcer. So this perforated peptic ulcer presents with rebound tenderness, borderline rigidity on exam, and severe sudden epigastric pain. It does not lead to bleeding. Perforation is different to bleeding. Please get that clear in your mind. All right? And so for a perforated peptic ulcer, think about it, it rupture. What we could do, we could patch him up. Patch him up, 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 patch him up. And this is called an omental patch. And that's how we'll treat that. All right? That's one complication. That's two complications, sorry. The other complication is we could have an ulcer, and this ulcer now is just staying there forever and ever and ever and ever. And that ulcer is intractable. So it just imprint itself there and he's not moving. Now, in an intractable peptic ulcer, we want to know what's the cause of it. So if a patient has an ulcer that is just not going despite treatment, you're thinking about Zollinger-Ellison syndrome. You're thinking about a gastrin-secreting tumor, that's an isolated gastrinoma. You're thinking about H. pylori that you never treated. You didn't give the patient triple therapy. So these are the causes or the reasons for an intractable ulcer that you have to exclude. But in any case, if the patient has an intractable ulcer, we're going to have to address that because that could become cancerous. And so for an intractable ulcer, if it's a gastric ulcer, we'll do what we call a Billroth 1 gastrectomy, which is where basically chop off the distal part of the stomach and they do an anastomosis, Billroth 1 anastomosis, where the proximal stomach is joined with the duodenum, right? So a Billroth 1 gastrectomy for intractable gastric ulcer. But if it's an intractable duodenal ulcer, we'll have to do a vagotomy. And the concept behind vagotomy is, remember, your digestive system is rest and digest, right? So we rest and digest. So it's parasympathetic. So the parasympathetic stimulation is responsible for acid secretion. So that means the vagus nerve is responsible for high levels of acidity. And so we'd have to cut out that. So a vagotomy, which is where you cut out some of the roots or the branches of the vagus nerve, it will inhibit the parasympathetic stimulation and acid secretion. So for an intractable duodenal ulcer, we'll do vagotomy. There is this concept of a highly selective vagotomy, and that highly selective vagotomy, please would associate, you do not cut, you spare the nerve of Latarjet. That is the crow's foot. And if you remember Latarjet, that's fine. It's supposed to be French, Latarjet. So highly selective vagotomy spares the nerve of Latarjet. All right? An intractable ulcer, we need to exclude those other things like Zollinger-Ellison syndrome and H. pylori, etc. But this is how we treat it with vagotomy in the duodenal ulcer case, and a highly selective spares the crow's foot nerve of Latarjet. Whereas in a gastric ulcer, we do a Billroth 1 gastrectomy. All right? Perforation, we'll do a omental patch. We said the most common site is the anterior first part of the duodenum. And remember, you will get a pneumoperitoneum. All right? So air under the hemidiaphragm. So they can simply bring you an x-ray with a pneumoperitoneum. I expect you're line year 5 with MBS next month. You know what a pneumoperitoneum looks like. All right? We'll do gastrographin studies in certain cases of perforation. The point is, we cannot use barium because if we do barium, barium is toxic to the peritoneum. And if that barium leaks out into the peritoneal cavity, it will cause a worsened severe peritonitis. All right? Spoke about bleeding. And that's that. Gastric outlet obstruction is lower yield. We'll do truncal vagotomy, blah, blah. That's kind of low yield. And well, cancer, gastric cancer is gastric cancer. All right? Good. That's peptic ulcer disease. Any questions there, guys? What is the difference between the different classifications of peptic ulcers? What do you mean, Julian? I'm unsure what you mean by that.
Well, since there's the scope, the Rockall, and the Glasgow Blatchford, I was wondering what the differences between the three of them were.
The Glasgow Blatchford score is a score that is used to assess the likeliness of your condition or your presentation being that of an upper GI bleed. Okay, that is used to assess that. So the Glasgow Blatchford, when a patient comes with bronch vomitus, you're going to have to Google Glasgow Blatchford. You don't have to know all the criteria, but you'll see things like an elevated bond creatinine ratio. You'll see patient has Malina stools. You'll see patient has cough ground vomit. It is used to assess whether or not your patient is likely having an active upper GI bleed, right? So it tells you whether or not your diagnosis is an active upper GI bleed. The Forest classification is used to assess when to actually treat your upper GI bleed. Your Forest classification, as you can see in this picture here, is where you do a scope and what you find on the scope. So the Forest classification is based on your endoscopy findings. All right, so you do the endoscope and you're going to actually see it bleeding actively, or it's not going to be bleeding, or it's going to have a clean base. And based on what you see when you do that scope, then you classify it as 1A, B, 2A, 2B, 2C. And based on that, remember I said types 1 to 2B, if it's anywhere where you have a high rebleeding risk, then you have to do something about that endoscopically. You don't want to achieve immediate cessation of that bleeding. So that's the indication for your Forest. And the Rockall scoring system is a risk stratification system to suggest the risk of dying from an upper GI bleed, and therefore also a risk to take the patient to theatre and so on. The one you need to know is this, Forest classification. You need to learn everything here. Does that answer your question?
Yes, thank you.
You're welcome. Any other questions, guys? 8 o'clock. We have lower GI to go. Woohoo! Sorry. Lower GI, the big bad boy in lower GI is colorectal cancer. So we'll take a little break and then we'll come back to it. Any other questions? Are we clear on upper GI, guys? Clear on peptic ulcer, clear on achalasia, clear on esophageal cancer, clear on GERD, clear on hiatal hernias. Are we clear on those things? We did 5 topics. Okay, Christina is clear. Are you all clear? Right, good. So we'll answer our questions, take a nice break, and finish up with lower GI after. Good. Number 1. A lot of people got this wrong. Answers to number 1 in the chat, please. Good, excellent. Why did you all say C? Why did you all say barium swallow? I just want to know. For those of you who might have. Anyone who chose C, can you tell me why I chose C, please? It helps. It helps when I get a feedback so I know what to tell my future students. So you'll be helping the future generation, guys. I like to know where students have shortcomings. Is it that you thought that barium swallow was the gold standard? Why did you all choose that? Hello? Okay, good. Right, so nice, so fantastic, right? So we would see things and we associate it. So we see achalasia cardia, we know we see in barium swallow, we see in that all the time, we see in bird beak appearance. Good. That is not the gold standard way of diagnosis. That is not the confirmed diagnosis. Right? Fantastic. Right? So, well, Sarah, that thought that it was a different thing altogether. So that's good. So now I know to stress to my students that even though you're seeing bird beak appearance, that's what they teach you. That is not how you diagnose, confirm diagnosis of achalasia. Because a bird beak appearance could actually even be due to esophageal cancer in the distal esophagus, because it's the same thing that will happen. You have a narrow lumen distally, you'll have retention of the barium within the proximal esophagus with a dilated esophagus. So barium swallow cannot confirm a diagnosis of achalasia. So that's fantastic that you are now clear on the confirmatory test for diagnosing achalasia cardia. And this, Sarah, this is a 3-month history of increasing difficulty in swallowing. And remember, Zenker's diverticulum is a cause of mechanical obstruction. And so Zenker's would present as difficulty swallowing solids first and then liquids. This year, presented swallowing liquids, right? She has difficulty swallowing fluid. That means she has a functional cause of this motility, not necessarily an obstruction in the lumen. Along with regurgitation and weight loss, and a chest radiograph showing a wide mediastinum is because of a dilated esophagus. This is achalasia gland. So B is the answer here. Fantastic. You're welcome. Right, number 2, everyone got. So which of the following is not an appropriate form of treatment for achalasia? Well, we can use pneumatic dilation. That's the best endoscopic way. That's the best non-surgical way. Pneumatic balloon dilation. We can use POEMs. LS cardiomyotomy is the surgical option of choice. We can do endoscopic injection of Botox. Where do we use up Ramsay pyloric myotomy? Pyloric stenosis, usually seen in pediatrics. And remember that pyloric stenosis is not congenital. It is infantile hypertrophic pyloric stenosis. It is not a birth defect. It is an acquired defect starting from the age of 2 weeks to 2 months. When we do pediatric surgery, we'll talk about that. Good. So number 3. I think most of y'all got this. So there's a patient with GERD, and which one of the following is least likely to perform appropriate management of GERD? Well, PPI, OMES, of course, prokinetics like metoclopramide to move the stuff along to prevent reflux. The gold standard surgery for GERD is laparoscopic Nissen fundoplication. Lifestyle modification for GERD will be to do weight loss. Where would you use a Billroth 1 gastrectomy, guys? Be specific, please. Where would we do a Billroth 1 gastro? In what complication? Good. An intractable gastric ulcer. Fantastic, right? You don't need to say gastric peptic, right, Judy? So peptic ulcer disease consists of gastric and duodenal ulcers. You just say an intractable gastric ulcer. Good. Number 4, I think most of us got. So, which of the following is not true concerning hiatal hernia? Barium swallow is the diagnostic tool of choice for hiatal hernia. Type 1 is a sliding hernia. We said that's where the gastroesophageal junction is intrathoracic, and therefore it's associated with reflux. Type 3 hiatal hernia is a combination of type 1 and 2. Type 2 is a paraesophageal hernia. And type 4 hiatal hernia is where you have the bowel contents. Sorry, you have the stomach, the GE junction, as well as other abdominal contents in the chest. And that could lead to gastric volvulus with Bouchard's triad, which is acute epigastric pain, retching without vomiting, and inability to pass an NG tube. So C is false. The gastroesophageal junction lies intrathoracic. No, that's not true. For type 2 hiatal hernia, that's where the gastroesophageal junction remains in the abdomen, but the fundus of your stomach herniates. Answers to number 5 in the chat, please. Excellent. So, endoscopy is not used to stage. It is used to diagnose. Staging esophageal malignancy can be used with ultrasound, endoluminal ultrasound, bronchoscopy, CT, and a laparoscopic staging laparoscopy. Endoscopy is used to diagnose, not stage. So that's B. Tricky question. So now you all are clear on that. Fantastic. Right. Answers to this one, please. Good. So the risk factors for squamous cell carcinoma: smoking, betel, alcohol, smoked fish. These are risk factors for both squamous and adeno, right? But Barrett's is a risk factor for adenocarcinoma only because of the mechanism. That's why I took the time and I drew it for you guys. You have squamous metaplasia, squamous becomes columnar, and distal